And the other thing I think we learned at the beginning is hope is not a strategy. So I just thought I'd share what some of the results were for process measures prior to doing one of the concept changes we needed to measure. So this is just an example, and unlike the other two presentations, this is not a controlled randomized trial, and that is a very difficult thing for the partnerships with physicians, and we had physicians on our team, is they're always looking for the validity that this happened with 200 patients, so then we need to do this. With improvement, it's not like that. If you pull 10 charts or you interview 10 patients and they've experienced this barrier in the system, guess what? It's a barrier, and it's an area that can be improved. It doesn't have to be 200 patients and shown to be over the full spectrum of care. So the model of improvement and measurement for improvement is very different than clinical research or controlled randomized trials. So for example, this is back a year ago, I guess, March 3rd to 14th in 2008. We just, it was the ward secretaries on the floor that helped us with this. They recorded what time people were by the physician told that they could leave the hospital, meaning they were discharged, and what time they actually left. So the median time for these 34 patients was 3.25 hours. And you'll see the two outliers up there. There was 22 hours. So someone was probably ordered that they could go home tomorrow, and then everything was done the following day and the person went home. So that was the median time. So then we said, well, what can we do about that? Obviously, we're missing something, that people are still getting a lot of discharge planning. If you look at the satisfaction surveys, they're still being given information as they're going out the door. So one of the things was, it sounds quite simple, but a visual trigger to everybody be communicating the same thing. Meaning if you're red, you're not ready for discharge. If you're yellow, you're going home in 2 to 3 days. And if you're green, you're going home within 24 hours. Meaning if I'm green today, I'm going home tomorrow. This is now used on whiteboards in the nursing stations. The interprofessional team meet for 15 minutes on 1A and 2B. They go through all 36 or 45 patients in 15 minutes, and it's basically so that the whole team is communicating with the patient and family, and there's a visual trigger in every patient room on 2B to talk about readiness for transitioning out of Thunder Bay Regional, so that the issues that are barriers to discharge come before they actually present themselves. So the goal is when somebody's green, if I'm green today, meaning I'm going home tomorrow, the goal is tomorrow my band is cut, so cut the band, shake the hand. All the things that need to happen for me happen today, or my family meeting, or my prescriptions written, or my follow-up appointments made. So, and then there's another one that's identifying if somebody's alternate level of care and waiting to go somewhere else. So this is just one of the concepts. So to show how we measured this was in October of 2008, we did it again with 16 patients. So again, it's not a randomized controlled trial. We didn't have 34 patients, exactly what we had in the previous study. And the median time came down to 1.4. So an improvement. So that's the way that you're able to say that these concepts that you're introducing, and we also went into all of these things saying that we may not see improvement, but we may improve quality. So, but we did have a time. So if you can get your head around where I've been going on this journey for the last 2 years is, if you multiply this from a general medicine floor where there's 110 to 120 discharges a month for the ones that have 36 beds, you're increasing the capacity in the emergency department, because if people go home smoother and more coordinated, the patients and family satisfaction is higher, but we're also able to get the patients out of the emergency room quicker. So it's not a huge change, but it's a small change over multiple people will improve the capacity in the system. So I just wanted to highlight that this is one of the templates for the sub-aim number 1, which was improving communication, to let you know that there was 54 PDSA cycles done. Tangibly, what does that look like today on these 2 units? Like I said, it's a whiteboard, it's bullet rounds, it's a culture change amongst the interprofessional team that we've always said at Thunder Bay Regional, we start discharge planning on admission. Now I think we have a better way of showing how we do it, because if you went into a family's room, with their permission, of course, like I've done when I've been doing audits, although people don't like the word, they can tell me what that sign means in their room. They'll show me the ticket to home. They can explain to me when, you know, it sounds like the patient and family will be leaving Thunder Bay Regional. So just to let you know that that's how many PDSA cycles it takes. It doesn't always take that many, but it's quite a few to get the outcome action items that you have tangibly to work with. So this is an outcome measure. So this is just showing length of stay or bed turns. So length of stay is down on the test units and the bed turns is up. Some of the anecdotes, just in summary, of what the experience was like. There's patients and families who have allowed us to use these quotes. I also should mention that we did a leadership report every month that went to the senior teams of both organizations, Thunder Bay Regional and the Northwest CCAC, and to the LHIN on occasions of bi-monthly, so that every month they could see what we were testing, what we were measuring, and what the experience was like. So we included things like anecdotes and successes. So this is just some of the things that people said. For example, you know, we had patients and families say, I knew when my husband was going home because the nurse came in and changed the sign. And that's really what we were trying to do, is improve the communication so that everything isn't done at the last minute. And it really was a quality improvement measure. For the team, they felt that as part of Team 2B, that their goal was to do was right for the patient every time. So getting down to, yeah, we do it on occasion, but are we doing it consistently with the volume of patients that we're seeing? So there was some variation there that we tried to improve on. I've just included, and it's very hard to see, but these are the final works of the FLO Collaborative. This is Team 2B's poster and where they started, what sub-aims they did, some of the things that they have tried, and what their measurements are and their next steps. So like I said, it is to spread to the rest of the units in Thunder Bay Regional, and hopefully out to the region, anything that we can share. I know the Falls Collaborative is started, the Regional Falls Collaborative, so I hope to be a resource and help with the PDSA cycles. So anything that can be lent from the FLO Collaborative or borrowed for other teams that are trying to work on improvement, we're quite willing to share. This is the sustainability and the spread plan for the next 12 months, so how we'll get all these out to the other units. And this is 1A, Team 1A's work. And they had a different focus, to be really focused on the transition to long-term care home and looking at that step process like I measured. And 1A really looked at transitioning people home. They looked at the palliative care piece and did a lot of work around that, had great success stories, and looked at some other measures. So with having two teams, it was a little different because we wanted to make sure we weren't testing the same concepts. So right now we're at the process of we're sharing each other's concepts and getting them out to each other's units. There's a resource manual that's been developed, and Ticket to Home, they're trying. So in conclusion, for the Northwest Ontario Process Improvement as an improvement advisor, how this will happen, a quote that I seem to like is that this will be done one process at a time with one patient at a time and done again and again to find out what works and what doesn't. Like I said, especially with alternate level of care, there's no silver bullet. Right now, the situation, the FLO Collaborative has contributed to, I'm sure, that, and all the other partnerships that we're working on the ALC situation. But it's going to be a journey and not a destination, and questions to ponder are what can be done by next week, next month, and next year to improve the system. Thank you.
Okay, thanks, Jennifer. This is good collaboration. I don't have to change.